Hi, everyone. This is Cameron again, and this is part two of our three-part summary of healthcare in America. So let's review quickly what we covered in part one. So we started by talking about how out-of-pocket spending developed into employer-based private insurance after the Great Depression and World War II, and then how the government stepped in to provide insurance for those who were unemployed, so mostly retired people and impoverished people. And the quote I used to summarize that was from the textbook. It said, healthcare financing in the United States evolved to its current state through a series of social interventions. Each intervention solved a problem, but in turn created its own problems requiring further intervention. So we kind of saw that as a theme, along with some other financial, ethical, and political themes, mostly involving community versus experience rating and whether government involvement is good. And so those have kind of been some things at tension with the story of insurance in America. And today we'll see some specific problems, and some of those are just problems that have yet to be solved, and then some of those are problems that were solved by other solutions to those problems, kind of like this quote explains. So let's get into that. So we'll cover quality, cost, and access. Those are kind of the three primary things that we focus on evaluating when we're evaluating the healthcare of a nation. So in general, I like this quote. Again, I pulled it from the textbook. It's not original to the textbook, but it's quoted in it. Describes the American healthcare system as a paradox of excess and deprivation. So America is pretty prominent on the world stage. So problems with low quality, unaffordability, and inaccessibility are all the more striking with such an affluent country. But as we'll see, there's lots of variety. And so that's the first thing I'm going to cover in the quality of healthcare. So again, paradox of excess and deprivation. One of my favorite artists, or not artists, authors, is Dr. Atul Gawande. So he is a surgeon and an author, and lately I think he's been doing a lot with public health. And so he wrote a book called Better, which is the cover is shown here, and then a book called The Checklist Manifesto, where it talks about how he worked with the WHO to create a surgery checklist. Basically, it's a 7-point checklist that they follow before surgeries, and it has actually prevented hundreds of thousands of complications in surgery that were happening every single year, many of which were life-threatening. And so it was a simple solution. So a lot of people were actually not too fond of it. People don't like to be told there's something simple that you've been missing and it's been causing lots of problems. But that was the truth. There were a couple simple things that were not standardized per se, followed by every surgeon, and it led to lots of complications. So there was variety that was solved by following the same little rules. And then he also talked about the bell curve. So if you put physicians on a bell curve, there's a large amount who we want to think that it's kind of skewed more to the right towards better quality, but in reality, it is more of a bell curve, normal curve, where most physicians would be in the center. And there's a few that do a whole lot better than others, and then there's a few who do a whole lot worse than others. And so specifically, he talked about how with cystic fibrosis, depending on which doctor you went to back in 2004, you could live 15 years shorter or 15 years longer than the average patient with cystic fibrosis. So variety is one of the problems in the quality of healthcare in America, because there are basically, it just means there's lots of patients who are not getting the healthcare that is possible and should be available to them. So oftentimes the reaction to variety is standardization. So I drew my own little bell curve here. It's not perfect, but it gets the point across. And we've got our X and Y axis. On the X axis is quality. So bad on the left, good on the right. And then amount of providers. So a little bit like the one he describes in his book, in that article on the bell curve. And basically what people fear that standardization does, and what in a lot of cases it actually does do, is it wants to make things more consistent. So insurance companies will say, this is best practice. So this is the rules that we're going to create, and everybody who has to everybody who's credentialed with our insurance company has to follow these rules for us to pay for this certain treatment. So they put a standard in there, and it does cut off all of the bad results. It cuts off maybe some over testing, maybe some negligence, maybe some just bad diagnosis. I don't know. So it cuts off some bad things, but then it also creates some limits for doctors who might have some other ideas about something that could help a patient. So I actually do know doctors who kind of reside here. They don't take insurance because it limits their ability to help patients who don't maybe fit the normal population as far as physiology and all of that is concerned. So, so some people don't take insurance specifically because they don't like these limitations. So in reality, what do we want a standard to look like? We want a standard to look like a vertical line. So it cuts off all the bad people, not bad people, but bad care. And it allows for that creativity over here. In reality, standards are probably a little bit more of like a diagonal or something like that. Anytime you put a standard, you're going to limit someone over here who's maybe a genius doing kind of these like miracle cures. But for the most part, I don't think they're quite as clear cut as the graph that I've shown, but I just wanted to get a point across there. So let's reflect on quality. Is standardization a good goal, or are there other solutions to variety? And does standardization stifle providers' creativity when it comes to solving problems created to patient variability? So not every patient looks exactly the same. So if we create a standard that's meant to, help 90% of patients, well, what do we do with those 10%? Does it limit their creativity in helping those 10%? And then does standardization prevent providers from overtreating or overtesting out of greediness or negligence for whatever reason that they're not doing their job very well? So does it actually work in stopping bad care? So some stuff to think about. One other thing you might hear about when it comes to quality is the cliff analogy. So this is my little cliff, and we've got a village on the top, and the village has a problem of the people falling over the cliff and not landing as gently as that. So they get together and they try to figure out, how are we going to solve this problem of people falling off the cliff? And they decide to build these big fancy facilities at the bottom. Of course, it's got wavy architecture because that's in style, and big expensive facilities that save the lives of people who fall off the cliff. So now they've got the system. When a person falls off the cliff, then they're able to save their life. But the person still probably comes away with some injuries, but at least they didn't die. That's a really good thing. Well, eventually, the only way to fund this facility is for the people who fall off the cliff to pay the facility. So the facility gets paid every time someone falls off the cliff. So one of the workers in this facility is thinking, well, we haven't really solved the problem of people falling off the cliff. We've just mitigated the consequences of falling off the cliff. So he's like, what if we did something to stop people from falling off the cliff at all? It was a brilliant idea, but he quickly saw the problem is that all the money's on the bottom of the cliff. So if people stopped falling off the cliff, he would be out of a job. And so would all of his friends and peers. Nevertheless, he is an ethical person. So he got together some people who were like-minded, and they presented the idea to the village. After months of voting and discussion, years of planning, they came up with this super complicated, high-tech, awesome solution. They built a fence, and that prevented people from falling off the cliff. So the cliff analogy is simple, it's exaggerated, it's definitely limited, as all analogies or metaphors or anything like that is, but it does make a point when we apply it to the American healthcare system. Do we have a sickness intervention system? Do we have just facilities that mitigate the consequences of being in a bad health position? Or do we have a health promotion system which actually promotes health and keeps people from falling off the cliff in the first place? So we'll refer to this cliff analogy. Again, it's not perfect, but I think it makes a strong point. So just to reflect on this quickly, are there any fences in healthcare that you can think of? And are there ways people can still fall through these metaphorical fences? And then will there ever be a point when facilities aren't necessary? So again, one of the limitations in my point of view of the cliff analogy is that there will always be people who fall through the fence. which means those facilities will always be somewhat necessary. But again, they are state of the art, they are high tech, which means they're expensive. So how do you transfer the money from the bottom of the cliff to the top of the cliff while still being able to fund the bottom of the cliff for those patients who need it every once in a while? So to illustrate this health promotion versus sickness intervention, I want to bring up the economic burden of non-communicable diseases. And this is just kind of a stark reminder. It could also fall under cost, but it does show the quality. So chronic non-communicable diseases are the current burden to most affluent societies. It used to be that communicable diseases were the main burden, but with vaccines and all that kind of stuff, we've eliminated a lot of the problems with communicable diseases. So now we're not being killed by polio and smallpox and all of that kind of stuff. We're being killed by heart disease and diabetes. So those are non-communicable diseases that are a burden to our society. So it's estimated that this costs us $265,000 per capita and $90 trillion in national expenses. So a huge economic burden to America. Just to put that into perspective, the national debt as of this week was 28.8 trillion. So if we got rid of diabetes and heart disease and those other non-communicable diseases, cancer, we could pay off the national debt 3 times. Not that paying off the national debt is a completely great idea, but it illustrates the point. So another way to measure quality is to compare us to other countries in similar economic positions. So here's a graph measuring US, Germany, UK, Canada, Japan, and these are just 3 main things: life expectancy, infant mortality, and mortality amenable to healthcare, which basically means the amount of deaths that could have and should have been prevented by healthcare. So as you can see, these are all developed countries. The USA has the worst numbers, and all these countries have universal medical coverage except for the USA. So these averages are skewed. So I want you to know that if you are thinking, well, I'd rather live 76 years in America than 77 years in Germany, I won't really argue with you. I'm kind of the same way, but you have to recognize that these are averages and averages get skewed. So for the most part, everybody's living about this 77 to 80. Japan's, really ahead of everybody with this 86, but, upper 70s, early 80s, most affluent people are living to that life expectancy. So this 1-year difference really isn't a matter of the affluent people. It's a matter of the people who are not living long lives who are skewing the results. So what these numbers really tell us is how well we are taking care of the people who have the lowest life expectancy. So the impoverished people in America, people who don't have good access to care, maybe people who don't speak English. These are the people who are, in a sense, skewing the numbers, or rather, we're skewing the numbers by not providing as good of care for them. So I also want to point out, anytime we compare healthcare between America and other countries, the topic comes up of, well, there are people in Canada who are waiting in super long lines, and so they come to America with cash to pay for medical care. And that's true. That's true. It's really hard to see a specialist in Canada. They have put the brunt of their money and resources into building a fence and not into the facilities at the bottom. So the people who inevitably still fall through the fence don't really have a good place to go when they hit the bottom. And so that's a problem with Canada's healthcare. But medical tourism is also a multi-million-dollar industry in America. So there are also, the other way around, Americans going to Germany to get chemotherapy because it's significantly cheaper and of the same quality, if not better. And so it's an interchange. It's not just other countries coming to America for top care, although that does happen because America is good at specialties. So that is worth noting. And then again, there are 19 total countries with universal medical coverage. The US is not one of those, but that's one of the things that's used to say the US should have universal medical coverage. and it doesn't. So why doesn't it? Well, because the US population is half of all of those countries combined. So I think that's important to remember because we're talking about universal medical coverage on a whole different scale. And we should recognize that because the techniques that these smaller countries use is not going to be is not going to easily translate into a country as big as the United States. And so that's just going to take some more problem solving. And lastly, those 19 countries do struggle with affording the healthcare that they provide for their citizens. Not all of them are single payer systems, not all of them are government run systems, but all of them do have an interaction between the government and the private industry. So it's good to keep in mind. And then interpretation. So I highlighted this 6.1 infant mortality in red because in my opinion, it's one of the most striking besides mortality amenable to healthcare. And since the first time I presented this information, I've actually heard a theory that sounds somewhat reasonable. I haven't validated it, but I do think it does well at illustrating how complicated these numbers actually are. So the theory is that the United States is really good at specialties. They're really good at bringing pregnancies to term, which would not have lasted under other countries' healthcare circumstances. So that means pregnancies in the United States are more complicated and more risky because doctors are good at bringing those pregnancies to term, even though they wouldn't have lasted in other countries. So that could potentially be a reason why our infant mortality is higher because we've got a riskier population that we're dealing with when it comes to infants. That could be true. It might not be true. It's probably true to an extent, but there are other factors that would also contribute to that number. So it's good to keep in mind that there's lots of reasons that these numbers could be different. There's multiple factors. Nevertheless, the USA does have the worst numbers across the board, and that's pretty humbling. So reflecting on quality. Would you rather have a healthcare system that prevented most people from being severely sick, but failed to take care of people who would nonetheless become severely sick? Or would you rather have a healthcare system that failed to prevent people from becoming extremely sick, but is relatively successful at saving them from death? And is this a false dilemma? Why not? Why are these mutually exclusive? Are these mutually exclusive? Is there a way to adequately fund the facilities at the bottom of the cliff as well as the fence at the top? And then how can we reconstruct healthcare finance to reward providers for their healthy patients rather than for their unhealthy patients? So let's get into cost. This will help us kind of understand why some of those questions are really hard to answer. So I mentioned this in part one, but it's worth mentioning again that after the ACA, this was in 2004, is when the survey showed that 46% of Americans still found it impossible or very difficult to pay for medical coverage. So how expensive is healthcare actually, and why is it so expensive? We're going to talk about a few reasons. So this is a graph comparing the US to other countries again, and OECD is just kind of the average of all of these countries. So as you can see, America is almost double the average of all of those countries, and this is in percentage share of GDP. So we spend almost double the amount of other developed countries. And if you translate this to per capita, that's about $12,000 per person. And there's a little line just to illustrate what the average is and how far above it we are. So it's important to kind of contrast this graph with the graph that we saw before about that we have lower health outcomes, but we're paying double what these other countries are. And keep in mind, these other countries are also struggling to handle the expensiveness of their own medical care. So that really puts into perspective how much we are struggling to afford medical care. So what are the major contributors? I'm going to give you just a minute or 30 seconds if you're on double speed to write down some reasons that you think American healthcare might be super expensive. So go ahead and start. All right, so this is kind of like a Dora-like scenario. I can't really see what you wrote, but I hope you got some good things down. And I'm going to go ahead and tell you what I wrote down and got from the textbook. So, wasteful expenditures, cost of becoming a healthcare provider, advanced technology and research, intense regulation, secret prices, and insurance and government subsidies. So we're going to go into a little bit more detail for each of these. So wasteful expenditures. One study revealed that 20 to 40% of diagnostic images may be unnecessary, and 21 to 34% of total health expenditures were considered wasteful. So a lot of potential waste, but you can see that those numbers are pretty broad. So I mean, who's going to be the one to decide that that's wasteful? You know, no one wants to be in that position because you're probably going to make a wrong choice and then someone's not going to get the care that they need. So that's really hard to identify. Some sources of potential waste are administration, because insurance is so complicated and it is extremely complicated. I'm going to try and make it sound as simple as I can, but it is extremely complicated. So that takes a lot of administration. Now, if you have family or friends or someone you know in healthcare administration, please don't hear me saying that their job is a waste of time. That is absolutely not the case. Technically, the job I'm working right now is a little bit of administration. I'm an insurance coordinator, so I don't mean their job is a waste of time. I mean that there is some potential ways to make things more efficient, and so that's something that we'll have to struggle with if we really want to cut costs and simplify insurance, as that could potentially lead to some job losses if that were actually to take place. I don't know if it will though. And then over testing and over imaging. We already talked about over imaging. Over testing, when the bill is guaranteed by an insurance company or by the government, why not add an extra test in there just to double check your diagnosis? That's kind of the mentality of some providers. It's going to be paid for and it's going to double check that I'm right or wrong, and it's going to give me more information to work with to better provide for my patient. So that's a hard one to determine if that's wasteful or not, but it could potentially be wasteful. So again, potential. I'm not going to be the one who decides whether or not that's really wasteful. So next one, becoming a healthcare provider. I found this interesting article that basically averaged everything that goes into being a doctor and then everything that goes into being a school teacher, and everything, the amount of money that you could make, and then average that by the amount of work that's actually put into it. So doctors have 8 or more years of higher education, 3 to 12 years of a low-paying residency, and an average debt of $285,000 before they actually start making any income. And then there's also the loss of opportunity costs. So they could have been doing something else during all of that time that made them more money. So how does that compare to a teacher? Well, when you add up the entire lifetime, according to this article, which was based on a lot of averages, so probably not representative of a lot of people. My parents are school teachers, and so they're like, I'm not sure that's really the case. But average lifetime of a doctor results in 3 cents less per hour than the average lifetime of a teacher. When you actually go in and look at that article, it shows that doctors work about almost twice as much. Again, my parents would argue that that might not actually be the case. So again, things are, there's lots of variation. But another cost is advanced technology. So I work at a facility that provides transcranial magnetic stimulation. Basically, it's like a little MRI coil that stimulates the part of the brain that's underactive during depression. So super cool, also very expensive. Robotic surgeries, I got to shadow a urologist who performed surgeries using the laparoscopy arms, but they were, or like rods. So you pop up the stomach, you poke the holes in the abdomen, and you insert these sticks in there with different tips on the end, and you can do surgery without actually like opening up the whole abdomen. Well, now they've attached those sticks to robotic arms, and there's a camera, and you can do it at a desk. So really cool, also really expensive. MRIs, CTs, X-rays, those diagnostic images we talked about earlier. Very necessary, very expensive. And then research. You can probably pull some numbers that you've heard of about people raising money for research, donations given to research. Research is also very expensive. So medicine just simply requires lots of advanced technology and consistent research, both of which are expensive. And then regulation. So guess how much it costs to get a drug approved by the FDA? It could be 1,000, 10,000, 100,000, million. But if you guessed a billion, then you were correct. So the final cost of bringing one product to market depends on a number of variables: the time, number of subjects in the research, complexity, disease, data assessment, and other considerations. So all of these make it 1 billion or more to bring a product to the market. So this was really eye-opening for me. It helped me kind of realize that big pharma has a lot of ethical problems. But when you think about having to invest over $1 billion into your next product, some products of which might not actually get to market, I can kind of start to understand maybe some of the reasons that they make what looks like an ungodly amount of money, is because you need a ton of cushion in your business to really be able to invest in another product, another medication. So we'll reflect on some of those ethical problems later. Secret prices. So New York Times article talked about the variation in the price of a complete blood count. It could be anywhere between $11 and $1,000, depending on the state, region, or insurance company involved. So that's pretty crazy. A complete blood count does not even cost $11. So the fact that based on the insurance company, it could cost $1,000 is pretty incredible. I think it's an example of how insurance can inflate prices. People basically decide, you know, I'll contract with this insurance company and I'll do this deal and that deal, and we'll only use this lab. And so we'll be willing to do this for $1,000. I don't know exactly what goes on behind those doors and those contracts and stuff like that. But this is an example of a huge variation in price that's not really reflective of the market value, which is a problem. So next, we've got insurance and government subsidies. So the government effectively guarantees that costs will be met. And so this can kind of be related to the problem with rising costs in higher education. So federal student loans guarantee that the cost of attendance at a university or a grad school will be met. And it's difficult. It's not the only factor for sure. There are 5 other things that I've listed on the reasons that I think prices could go up. But this is definitely one of those things that we need to remember, because it's really just financial cause and effect. This is not me saying that the government should not be involved in education and medicine. I don't think that. But when we're getting to problem solving about finances, we need to recognize the results of the government using money to help people get education and healthcare coverage. It does result in some of these problems. So I titled this commercial insurance, but actually I'm just going to go through some vocabulary with you just so we're on the same page. So a premium is a monthly payment for an insurance plan. So, and then that's usually balanced with the deductible, which is how much you have to pay before your insurance will start helping you with medical costs. So usually premium and deductible are kind of in an inverse relationship. If you have a high deductible plan, that means you're willing to pay more money on your own before your insurance kicks in. And so to do that, you're going to pay less money per month. And then vice versa, if you have low deductible, you may only have to pay $1,000 before insurance kicks in, but you're paying, you know, a large amount per month. I don't know what all the numbers are relative to each other, but I do know that even $500 is a pretty small premium in some cases. So what happens when the insurance company actually starts paying for you? Well, you've got co-insurance or you've got a co-payment. So co-insurance is basically, you know, we'll pay 70%, you pay 30% of whatever you have after you meet the deductible. It's usually 70-30, 75-25, or 80-20. And then there's a co-payment. So you either have co-insurance or co-payment. You rarely have both, but a co-payment would basically be, okay, every time you go to the doctor, it's going to be $25. And that might change a little bit depending on which doctor you see. But $25, $20, $30, and then insurance pays the rest. And then there's a total out of pocket. So if you're paying your co-insurance, you're paying your co-payment, and you know your deductible was $6,000, and now for this entire year you've spent $10,000, and you've reached your total out-of-pocket maximum, then basically insurance is like, okay, you've spent enough money, we'll pay for everything else beyond this, because ideally that would be a pretty atypical year for you and for the insurance company. So they're like, you're in some kind of medical emergency, we're going to pay for the rest. And then there's tax credits. So basically, if you make between 133 and 400% of the federal poverty line, then you can purchase insurance through healthcare.gov, and they will apply a tax credit to your premium. So they'll basically help you pay your premium. So in a sense, to make healthcare coverage more affordable, hence affordable care, Affordacare. And then health savings account. And this is basically a non-taxable savings account reserved for only medical expenses. It can only be used to pay off the deductible, not to pay off the premium. So in part 3, we'll talk about how one of the trends in primary care is going to produce a little bit of a problem in that definition. So government insurance. Medicare is split into 4 parts. Part A is going to cover inpatient care. Part B is going to cover outpatient care. Part C is a combination of both. And then Part D, covers prescription drugs. And there's a little donut hole in Part D that you might hear about. Basically, it's a gap in coverage. And then Medicaid is state-run for poor and categorical citizens, so maybe people with a disability. And then CHIPS is a subset of Medicaid for children who live under 200% of the poverty line. And then there's some criticism against government insurance, as there probably always will be. There's major gaps in coverage. Coverage is farmed out to private insurers. There's no negotiation with pharmaceutical companies. So as we talked about earlier, people can, raise costs and the government will guarantee that they'll pay for it. And then it's confusing to patients, physicians, and pharmacies. And that's the truth. It's confusing. But I will, just to give Medicare a little bit of credit, for my clinic specifically, it's not my clinic, but the one I work at, Medicare is actually one of the easiest insurance companies to work with. So for us, it's beneficial to take Medicare, and for other clinics, it might be extremely beneficial to take Medicare, and it might be the only insurance that they take. For other clinics, it might be extremely inconvenient to take Medicare, and so they won't take it. So it really just depends on what kind of practice it is. So those are some criticisms listed in your textbook. And then let's talk a little bit about universal medical coverage. So we've talked about how insurance inflates the price of medical services. We've also talked about how insurance helps people afford those higher prices. So in summary, insurance makes healthcare both more expensive and more affordable. And that's an idea that I kind of want to drive home because the goal here is affordability. So ideally, expensiveness really only becomes a barrier to healthcare when it's so expensive that it keeps people from affording healthcare. And that's where it is right now. So if everyone were able to have healthcare insurance, then the expense would not be as important, but it's still pretty important because it's about how we allocate our resources. So that's kind of a macroeconomics kind of topic. And then let's reflect on the cost. So what are some wasteful expenditures that contribute to America's high national healthcare expenditure? And then considering the high cost of getting a drug approved by the FDA, is it reasonable for big pharma, quote unquote, to be grossing more than most for-profit companies? And even if you can make some business and some business sense of that, some financial sense of that, is it ethical? There are a lot of people who need certain types of drugs that are very expensive, but there's a small population of people who need them. So the company needs to make that money back on a small percentage of people, which means price is going to be super duper high. Is it ethical to do that? How would we do that ethically? And then number 3 is the cost of healthcare in America a good indicator of the quality? Are we getting what we pay for when we pay double the amount of other countries? And do you personally pay more for better care or less for worse care? And why or why not? So good things to think about. We'll talk about access very, very briefly. So this is a graph primarily of, we already talked about financial barriers to healthcare in the cost section. So this will talk about geographic barriers to healthcare. So the green is where basically it's split up between specialties and primary care. So the green is where these group of providers exceed the percentage of the population that lives in this area. And then the red is where they do not. There's not enough of these providers for that particular area. So you can see probably what you would have expected in an urban setting. There's more specialists than are really necessary, and there's less primary care physicians than are really necessary, or providers. This includes NPs and PAs. And then in rural settings, there's less specialties and more primary care. So that's about what we would expect, except when it comes to primary care, there's also a little bit less primary care as we get into the remote rural areas. So those are important things to remember. Some people might not have access to specialists, or they might need to drive across the state to see specialists, which is the case sometimes, especially in Abilene. People drive 2 hours to see the doctor in Abilene because the only other doctor nearby is in Lubbock, which would be 3 hours away. So, and then I also want to briefly touch on social and legal barriers. So legally, citizenship or lack thereof can be a barrier to healthcare. And then socially, we're still dealing with both personal and systematic racism. I recently interviewed at a school where the medical students kind of had some time to talk with us, and they're like, we love our school, but one of the problems that we've seen is our curriculum is still based on white males. And we know that there are some maybe relatively minor, but there are still real physiological differences between male and female and different races. And so they've been pushing for more diversity in their curriculum. And the school's been responding to that. So that's good, but I mean, we are in 2021, we shouldn't still be basing our education on white male anatomy. So that's an example of systematic racism. And in conclusion, we'll do a summary and short reflection. So we've got our summarizing quote is a paradox of excess and deprivation. And then we've got quality. We talked about the tension between variety and standardization. We used the cliff analogy to show how America's maybe a little bit more of or a lot bit more of a sickness intervention versus a health promotion system. And then we showed some of the lower health outcomes of Americans versus other countries. And then in cost, we talked about how we pay double what other countries pay as a nation. Maybe you don't personally, but as a nation we do. And then the reasons for that expensiveness. And then we talked about just a brief explanation of commercial versus governmental insurance. And then access, we talked about mostly geographic barriers, but also social, legal, and the financial barriers were covered in the cost section. So let's reflect. After learning this information, does universal medical coverage that is accessible, affordable, and of good quality seem reasonable in America? And can universal medical coverage in America be realized without the intervention of the government? And if yes, what must change about society in order to reach this goal? If no, can it be done by the government alone, or is it necessary to partner with existing companies? So if you totally believe like, yes, the government should run everything, why is that the case? Why do you believe that? And how should we be involved if that is the case? And then if you believe, no, the government should absolutely not have anything to do with healthcare, well, then what really needs to change about society in order to reach that? And then 3, is standardization according to insurance requirements the best way to reduce negative variety in the practice of medicine? If yes, or if no, what are some other ways to reduce the variety and the quality? So I think it's important to remember there's probably more than one way to do things. And then 4, should healthcare be strictly budgeted to reduce costs? If yes, who would enforce a budget? And would they be trustworthy to determine what are wasteful expenditures and what are not? And if no, what are other options you can think of to cut costs? And why would those options be more effective than a budget? So I will be honest with you, I don't have answers to all of these questions that I'm throwing at you, but I think they're important to think about because hopefully you will be in a position of some influence as far as policy goes. If you don't want to be a policymaker or anything like that, you'll still be asked questions like this, and your input will be very important to that. So try to keep these things in mind, and I'm sure your answer will fluctuate a little bit with your experience as well. I've mostly just read some textbooks, so I'm learning these things too. But that's all for today for part 2. Here's some references and my visuals. So thank you for listening and have a great day.